ado, I am very pleased to introduce our speaker. Dr. Jack Annunziato is a physiatrist and he is the medical director of ambulatory and rehabilitation services for Valley Medical Group and for the Valley Health System. Dr. Annunziato did his education at Rowan University and his fellowship with Morristown Medical Center, osteopathic neuromusculoskeletal medicine. He did his internship and residency at Mercy Catholic Medical Center and Rutgers, New Jersey Medical School. He is board certified with the American Board of Physical Medicine and Rehabilitation, and we are so pleased to have him speaking for us today. Thank you, Dr. Annunziato. Appreciate you being here.
No problem. Thank you for having me, and thanks to everybody for taking time out of this nice day. Hope to get you back out in the nice weather soon. But I'm going to share my screen and we'll just get right started. All right, here we go. So, uh, screen.
Here you go.
All righty. So today I'm going to talk about back and joint arthritis and how physiatry can help. All righty. Let's go forward. Oh yeah, sorry. I am medical director for Valley Medical Group's ambulatory physical medicine and rehabilitation services. So my goals for the lecture today are to explain and show what arthritis is, to explain the role of a physiatrist and how we address back and joint arthritis, and kind of talk about some of the treatment options that may be available to you. So what is arthritis? Arthritis is basically the result of forces, both mechanical and biological, that interrupt the homeostasis or the balance between the maintenance of cartilage and bone. There are a lot of different kinds. Most arthritis that we talk about is what we call osteoarthritis, but there's rheumatoid arthritis and reactive arthritis and infectious arthritis, and those types can be better triaged by your physician. But for the majority of people, when they say I have arthritis, they are thinking about osteoarthritis. So as I said, osteoarthritis is the most common joint disorder, and it's actually the second most common form of disability in the United States. Things that make you more risk for osteoarthritis of a joint: aging, people who do repetitive tasks, people who are heavier, if you've had an history of injuries or traumas. And there is a genetic component to it, and even a sex-based component to it. We find that women have arthritis more commonly in their hands and knees than men. And then we talk about back pain. And, we know that about 84% of us, or almost all of us, will have low back pain at some point in our lives. We know that basically 12% of people will get a flare of back pain that prevents them from doing their activities of daily living. And we know that risk factors, again, include age and obesity. Female sex are more likely to have it. And then different kinds of work, either very strenuous work or people who are sitting at a desk all the time, sedentary work. We know that there's a correlation with smoking. We know that there's a correlation with anxiety and depression. Being unhappy with a job can lead to more back pain. And we also know that there's an educational component to it as well. I really like this slide because it kind of describes the process by which arthritis comes, and it kind of talks about how there's a bunch of different factors at play. So in the top left corner, it's like what predisposes you to osteoarthritis: your age, some genetic factors, and some systemic factors like obesity. But there's also a biomechanical thing. The type of work that we do, maybe an overload, or there's an issue with that joint. There was a prior injury that leads to maybe instability. So you have a predisposition and a biomechanical process that sets off this biochemical pathway, different inflammatory markers, and that leads to a location and a severity of osteoarthritis. Then you factor in all the other things that lead to arthritis. Maybe the patient has diabetes and they don't heal as fast, or maybe there are financial or socioeconomic or psychological stuff that also crowds their pain. We have patients who have pain and they have bad anxiety, and their anxiety flares their pain even more. And so that kind of trickles into pain. And then from pain, you can have disability and the sense of distress. So I really like this slide because it's not just a joint issue. There's a big constellation of factors that play a role, and addressing any one of these, if possible, may help a lot. So when they have osteoarthritis, what do they notice? Some people get either chronic pain or intermittent joint pain. It can describe morning stiffness. They wake up and, oh, I just don't feel right. Feels kind of sore, feels kind of uncomfortable. There's a sense that they can't do the job that they like to do. I ask sometimes with hip arthritis, when was the last time you wore a pair of shoes that required laces? Suddenly you're using slip-ons and you don't even think about it, but it's easier to do it that way. Sometimes there's a sense of like, oh, it just doesn't feel at the right place. I'm uncomfortable walking my knee. It's gonna give out. And that pain can be dull. Um, and initially it's like, ooh, maybe this is when I do something, I feel it. And then it gets better with rest. But then there are some patients where the arthritis, the pain is all the time, even at rest. So it becomes an issue. People describe the sensation that their joints get stiff, and we call this articular gelling. And sometimes you have to warm up. We'll tell people, oh, warm up your day. Start with a hot shower, get loose, and you're like, oh yeah, I do feel better after I take my shower in the morning. And you're trying to fight that articular gelling. You may hear noise, like I get all the time. My neck hurts, and I feel like I turn my head, and I hear crack, 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 crack. That grinding sensation. That's what we call crepitus. And some people, when they're walking, it's like, oh, I can't trust my knee. I feel like it's going to give out. That sensation, like it's going to give away from you. So these are all signs and symptoms of osteoarthritis. Like I said, sometimes it could just be one joint. It may not be both knees. It might just be one. The joint itself can feel tender. Women, especially in their hands, like, ooh, my hands, they hurt. Touch hurts the touch. They may feel like their fingers are getting bigger. Or my knee just looks so big. Or the little range of motion. I can't put my pants on. It's really tough to lift up my leg. Hearing that noise or pain with motion. So these are all the things that we hear about. So when you go to a doctor, you want to expect a couple things, good history and physical exam, x-rays to take a look at it, maybe some lab tests if needed. And, I get patients all the time. I got this report as x-ray. It says I have all these different things. What do these things mean? Some of the things that might come up in that report. Oh, I have subchondral cyst formation. And we'll show you pictures of what that is. They might say the bone looks remodeled, like it changed shape, or there's sclerosis. Um, some people have had arthroscopic, and they describe how the bone looks. And they took their reports, like the doctor did a scope of my knee, and he said I had eburnation. And I don't know what that means. It's like, oh, well, eburnation means it looked white and shiny. They may have narrowing of only one side or a different side, or they may have osteophyte formation, which might be sometimes called a bone spur. So I like using this next slide to kind of talk about it. So these are knees, and you have a lot of stuff going on. The arrows highlight what are called joint space narrowing, but there are uh, thin lines. This is subchondral sclerosis. For pictures a little cloudy, but this kind of darkening. This is a subchondral cyst over here. And so these are different things that we can identify to you on your x-ray. It's like all of these are signs of arthritis. This is an example in the top left corner of eburnation. This is what normal hip bone looks like. And then this is the abnormal. This is that smooth shininess. And then on this bottom, this is a histological slide. So if someone took a bone biopsy and you're like, okay, this is normal cartilage, I'm going to show you in a little bit what abnormal looks like. So abnormal cartilage almost looks like it's frayed, almost like it chops into it. And then this is an example of what a subchondral cyst looks like if they took a hip and then they looked at the hip after they cut it out. And so they have this almost like gap in the bone, like it got scooped out by a melon baller. And then I get this time, oh, I have these nodules on my hands. That's arthritis too. If it's closer to the tip, we call it Heberdens. If it's closer to the middle joint, we call that Bouchard's nodes, named after the docs that kind of figured this out. And then when we talk about a back, oh, I got arthritis in my back. I got a disc bulge. I got a herniated disc. I got a protrusion. I got an extrusion. What do all those words mean? The words may not matter to you, but they matter to the doctors because it kind of describes what they is. We use herniation as kind of a catch-all, kind of like how people just say, oh, I have sciatica, but sciatica could be a dozen different things. So normally what we have are a normal disc that's like jelly donut wrapped around a bunch of layers. And then if we go to what a disc bulge is, maybe that jelly donut is kind of pushing outward. Sometimes that jelly can get stuck, and we call that a protrusion. And then if it gets past the disc itself, we call that an extrusion. And then if that disc got cut out and kind of floats, we call that a sequestration. So you may say I have a herniation, and that's true, but there's lots of different types and ways to characterize this. And that can impact you in a lot of different ways. So this is a description of back pain. They have spinal stenosis, and here we see, okay, they have a herniated disc that may be crowding a nerve root, or there's spur formation or arthritis of the bones itself, and that creates irritation. Maybe that arthritis is at the facet joints, and that causes irritation of the nerve. So there's lots of different areas. Some people call their arthritis, oh, I have arthritis. It's like, oh, actually, you don't just have arthritis, you got a compression fracture. And it's this little divot here, and it's kind of pushing out that bone into the space where those nerves go. They may have Bertolotti syndrome, where it's almost like they have the lateral processes start to connect with a bone below it. So I give these examples to kind of tell you there's a lot of different types of arthritis, and people get arthritis in all different places, and it may be affecting you or a loved one of yours. And then it's like, all right, well, what do I do with this stuff? So this is the role of physical medicine rehab or physiatry or PM&R because there's a lot of words and it's tough to say. So PM&R physicians, also known as physiatrists, we treat a variety of medical conditions. It's from brain, spinal cord, nerves, bones, joints, and ligaments and tendons. The thing you need to know is this is non-operative care. So we're not an orthopedic surgeon. We're not going to cut you open. We try to deal with things non-operatively. And, we try to impact these conditions so that you can go back to doing things like working or doing pickleball or your recreational activities or managing your mobility and just, helping you get back to your family and community roles. We are kind of a collaborative specialty because most people don't know what we are and they're like, oh, I heard of you through somebody else. So, we interact with your primary care doc. Sometimes we help focus on, with a neurologist if there's a neurological disorder and maybe you need adaptive equipment. We try to manage your arthritic conditions prior to needing either an orthopedic surgeon or a neurosurgeon if it's, has to do with your back. Sometimes there's joint pain associated with cancer, and we try to deal with that with your oncologist. There is pain, pelvic pain, sometimes we deal with. And so a lot of times we collaborate with your OBGYN. Not, as I mentioned, not all arthritis is osteoarthritis. Sometimes it's rheumatologic, and we have you meet with a rheumatologist. And we do a lot of interaction with all types of therapists, physical therapists, occupational therapists, speech language pathologists, if it's a neurologic issue, and orthotists who help design our braces if it's custom braces are needed. We manage a lot of stuff besides back and joint arthritis. So I know we're talking about back pain and joint pain because they're the most common, but we see people after they've had big neurologic injuries like stroke, spinal cord, traumatic brain injuries, and concussions. We help people with their ambulation if they've had multiple sclerosis or polio. Some physiatrists specialize just in burn injuries. Some physiatrists just manage cerebral palsy and neurologic injuries from childhood. If you've ever seen somebody with an amputation, oftentimes the physiatrist is the one who's managing their prosthetic limb, making sure it fits well, making sure that they don't have any skin issues related to it. We handle occupational injuries. We see athletes who throw. We see runners who run too much and they hurt their knees or their foot. That could also be overuse injuries. We manage some neurologic conditions like neurogenic bowel and bladder. Sometimes we help with pressure sores. Sometimes you need the right adaptive equipment so that you're not putting pressure on your tailbone so you don't get wounds. We handle tight muscles, sometimes from a neurologic injury like chronic from spasticity. And, sometimes pain just lingers and we help deal with chronic pain. So we do a lot. And, that kind of sums up who my patients are. It's young and people and old people because the conditions can come at any time. And, this is just a list of things that we see commonly, but it's by no means exhaustive list. But, top down headaches, migraines, TMJ, neck pain, back pain, different herniated discs, pelvic floor pain, SI joint pain, pain related to pregnancy, golfer's elbow, tennis elbow. I see rotator cuff injuries, your pickleball injuries, your carpal tunnel stuff, pain that's associated maybe with anxiety and depression. Some people think they have fibromyalgia. That we see too. If there's mobility equipment, you can handle walkers, braces, wheelchairs. Obviously arthritic pain, but neurologic injuries, cancer pain. I could go on and on. So where can you see a physiatrist? I am in an outpatient office, but a physiatrist may be part of your care while you're in an acute hospitalization. They may see you at a rehab or a skilled nursing facility. There are spine centers, including Valley Spine Center, you might see the physiatrist. We're in pain management practices, and we're in orthopedic clinics. We kind of manage a whole bunch of stuff. The thing you need to know about PM&R physiatry is that we focus on the quality of life. And so we have these tools in the toolbox to help a patient. And you may come into a patient exam not knowing what you need, or you may have tried a bunch of things and you're like, hey, listen, I need an alternative. And so we talk about, all right, is there the right exercise that I can do? Maybe I do want a medicine. The pain is a little too much. Sometimes there's a question of, well, what can I do when you're not here and not in the office? All right. Should I use ice? Should I use heat? What about a TENS unit? What about a massager? What about ultrasound? Talk about that. We really want to make sure that you're getting care that focuses on your mobility. So we try to help with that as best as can. Sometimes that involves what type of brace should I be wearing when I'm doing a sport? Or, my foot's starting to drag. Should I be in a bigger, bulkier brace? Or, you know, should my loved one start to use a rollator instead of their cane because the balance is a little questionable? And, we have injections as well. And, we in this office tend to do them under ultrasound, but our pain management colleagues do them under x-ray if needed. And we talk about those. So, what to expect when you come see myself or one of my colleagues? Expect a thorough history. We want to get to the bottom of what's been going on and we want your full story. We want to know everything you tried, what drugs you've taken, did it work, did it not work, did you have any reaction to it? Have you had a shot? Was it guided? Did they do it with an x ray or an ultrasound or was it unguided? Do you remember what you have? We're going to do a thorough exam. We're going to make sure we know, based on our physical exam, what to expect, what to look for. And sometimes you need tests to confirm what we're looking for, whether that's an X-ray or an MRI, or maybe some blood work, or, in the case of some neurologic injuries, do I need to send you for a nerve conduction study or an EMG? And you're going to expect that we're going to give you not just a cookie cutter option, but we need to discuss all options because maybe one thing is right for you that you haven't tried, or maybe something that was tried before should be avoided. We need to have that discussion. So a lot of times get to talk about, well, what are my options from a pharmacologic and break it down for me. And so medicines are something that we talk about often. We talk about your anti-inflammatories, and some of these are over the counter, like Advil, Motrin, and Aleve. Some of them are prescription strength, and you may find that maybe the over-the-counter stuff isn't working for me, but your prescription version is needed. There are muscle relaxants, and they all work on different receptors, so there's different kinds that we'll use. There's nerve pain medicines like pregabalin or gabapentin, and then there's serotonin-based medicines. People don't think about using an SSRI as a pain medicine, but if you think about it, the chemical receptors in your brain that respond to pain, uh, they include inflammatory markers, so we know why those work, but they also include things like the CBD receptor, which is in marijuana. They include the serotonin receptor, well, that's the antidepressants, and that's the opioid receptor, so that's opioids. So we try to use medicines not because we think, oh, you might get more relief, but it's like, hey, listen, this medicine works on a totally different pathway than something you might have not have tried before. Maybe anti-inflammatories were not useful for you, but there are other classes of medicines to consider. The only thing I would say is one of the things that we want to know is your medical history. And so some people will reach for a bottle. Oh, this worked for my husband. I started taking it. Oh, this worked for my cousin. They gave me the rest of their bottle. Medicines have interactions. And, it's not your job to know all the interactions. It's our job. But we want to know what you've been taking. And sometimes there's risks. Just actually today, I had an example. Patient was taking a leave, but they're on Xarelto. They didn't know that Aleve is a blood thinner. They just were told no Advil. So they thought Aleve was fine, but it's actually the whole class they can't have. And that's a very common occurrence, unfortunately. So, at the very least, if you're taking something over the counter or you're taking a pain medicine, talk to your doctor about it. We do a ton of procedures in our office. We do things like cortisone shots. This can go to a variety of areas, shoulders, hips, knees. The gel shots are something that we use for knees that are approved, insurance covers. And coming soon at Valley, hopefully next month, we'll be offering platelet-rich plasma injections. And I can talk more about that if anybody has any specific questions about those. We do Botox injections, both for migraines and also for tight muscles. And then there are spine procedures, which often are done by our pain management colleagues that we utilize. Some PM&R doctors are pain certified, and including at Valley. So, like Dr. Parvez is one of them, and she does our spine shots. Um, and then there's osteopathic manipulative treatment, which I'll talk about a little bit about as well. Then some people are like, "Hey, listen, I don't wanna talk about meds at all. I don't wanna talk about procedures. What are the non-pharmacologic options?" So a lot of times, it's activity modification. We will talk about your lifestyle. Sometimes it's, "Listen, doc, I work at this desk all day. Maybe the right setup for my shoulder pain is bringing the keyboard in a different place. Maybe I need a standing desk," to talk about those things. Weight loss is huge. When we talked about risk factors, um, weight gain and obesity plays a huge role, especially on joints and knees. So one of the things I'm actually boarded in is obesity medicine, and those new class of medicines, those GLP-1s like Ozempic, Wegovy, Mounjaro, and Zepbound. We'll write for those medicines to try to help manage the pain because if we can take pressure off the joint through weight loss, then we fix the problem or help alleviate the problem. We are supposed to be the experts in what therapies you should have. And so we might write up a detailed physical therapy, aquatic therapy, or occupational therapy script. We talk about different braces. Those are our joint protection modalities and equipment, like a cane, a grabber, things like that. We talk about things that you could put on yourself, like an acupuncture machine, a TENS unit, and osteopathic manipulation. Oftentimes we talk about what's my exercise prescription? I just want to know what to do. How do I stretch this out? How do I strengthen it? And really what we tell people is our goals of exercise is to increase your strength, your range of motion, limit your pain, maintain or improve your function, and protect your joints. People think, I have joint pain, I shouldn't do anything with it. And it's actually the opposite. We want you to be moving more. It's the familiarity with motion that will help. And sometimes we joke, motion is lotion. It's really important that we want to keep you moving. Therapy prescriptions get detailed. We want to do some degree of muscle conditioning, some degree of flexibility stuff. Sometimes you have a new adaptive equipment and you need training, and the physical therapist will work with you on that. And we talk about how to keep your posture or what your joint positioning should be when you do an activity. Just the other day, I had somebody who was coming in with writing cramps. I gave them a piece of paper. I was like, hey, show me how you write. And then they were loading their wrist in a way to avoid smearing because they're left-handed, like me. And so it's like, all right, we got to talk about how to maybe change this so that you write in a way that, maybe it's a little weird for you, but oh, listen, there's no pressure on my joint anymore. All right. When we talk about how to use a cane, like a straight cane, and maybe if your cane is because you have left knee pain, you should be using it on the right side. You don't even think about that. When to use a rolling walker and a standard walker. Um, and lastly, one of the things that I specialize in, I'm boarded in, was what's called osteopathic manipulative treatment or OMT. So OMT or osteopathic manipulative treatment is a series of therapeutic techniques that we use to diagnose and treat and prevent illness. They are gentle pressure maneuvers with some degree of resistance, usually sometimes a pull or a push, to help promote better function and it's age appropriate for everyone. I treat newborns to I think I have a patient who's 100 and I take care of her. Uh, and the goal is, hey, listen, this is a tool in the toolkit that maybe can keep you off of a medicine. So an example of OMT is this. This is suboccipital release, and I'm basically applying a little pressure just under the head to release the tight trap. And the goal is to stretch the muscle, increase motion and pliability, and encourage, fluid movement within the soft tissues. Another one is called gluteus muscle energy. So this patient has kind of tight hips, and I am stretching their hip. I'm pushing their hip across their body towards their left side, and they're pushing against my resistance, and I'm taking them into a further stretch. If you've ever watched a sporting event, pro sports before they start, you can see them often with a personal trainer working out some of these muscles. They're using these activities. What they're doing is they're activating what's called the Golgi tendon reflex that all muscles have to promote better range of motion. Um, it's a good warm-up motion. And so sometimes we'll start with this type of technique before I take your hips into a range of motion exercise. And then sometimes it's not exactly a violent or big motion. Maybe you don't have a lot of movement. What this is counter strain. We're applying a slight pressure here with my left hand on my ring, index, and middle finger, and I'm putting the muscle up to their upper trap in a shorter position. I'm putting it in a position of maximal ease. And by holding that position, uh, the muscles that counteract it relax to your force. And so if you think about countering muscles, you have your bicep and your tricep. If you activate your bicep, you're curling your elbow in, and if you activate your tricep, you're extending. But for your arm to go in one position, one muscle tightens, one muscle softens. And that's the whole premise of counter strain. You're trying to get both of them to soften at the same time so then you can do the movement. I just want to say a special thanks to the UMD&J School of Osteopathic Medicine Rheumatology, because some of those clinical pictures I borrowed from them, and they're phenomenal pictures, and I wanted to share that with you guys. And at this point, you feel free to take a picture and a screenshot so that you have our contact information. We are over at the old Ridgewood campus of the Valley Hospital on the second floor of the Bergen building. And if you Google us, it'll show up. But I will stop sharing my screen and we will open everything up to questions and we can kind of make this about you guys. Thanks.
Oh, thank you so much, Dr. Nunziata. That was so interesting and comprehensive, and it really describes all the wonderful work you do. So thank you. A couple questions. Someone asked, is there a Valley neurologist whom you know who has expertise with S1 nerve conduction problems? And I guess how often do you work with neurologists? May also
Sure,
be part
yeah.
of that. Yeah.
So oftentimes when people have a known S1 radiculopathy or a pinched nerve at the S1, um, a lot of times there's different modalities that both us and the neurologist will do. So, you may see, medicines like gabapentin or Lyrica, and sometimes we can manage that or your neurologist does. Valley actually does not have any neurologists per se, but
Mhm.
the neurology group of Bergen County is kind of the practice provider that supports the hospital. And so they're a great big practice. They're in Ridgewood, and we often refer with them.
Right. Great, great. Um, and could you again just sort of explain the difference between a physiatrist and a physical therapist, if you could?
Sure, I get this all the time. So a
Hmm.
physiatrist is a physician. We are experts in kind of diagnosis and writing the treatment plans that a physical therapist may execute. So you'll come to a doctor, let's say, once every couple of months to check in, see how the progress is doing. We'll go over your x-rays, we'll go over your um, imaging, we'll talk about medicines, talk about what braces you need. And then we might say, hey, listen, you need physical therapy. Let me write the script of what things they should be focusing on. And then you bring that script to your physical therapist. And they're the ones who might see you twice a week for 6 weeks or something like that to go, okay, Dr. Nunziato said I need to build up my quad strength for my knee pain. How do we do it? And he said that these might work for me. And then you go and do those exercises under their supervision. So that might be the
The difference.
similarities. Yeah.
Great. Um, so how would OMT and chiropractic care differ? It sounds sort of similar, someone asked.
Great. And we get that often a lot too. So, um, again, OMT is done by a physician. So they're done by osteopathic physicians. And
Mhm.
so, in addition to OMT, we're also talking about some of the more medical based things that we're doing, like medicines, um, uh, imaging orders, bracing, stuff like that, that some chiropractors are not able to order things or like meds and stuff. The other thing is in the types of treatment styles. So
Mhm.
an osteopathic physician who does OMT typically sees a patient infrequently. I may see a person at most once a month, and there's a philosophical approach to that that may differ than the chiropractor. Um, Everything that we do is done by our hands. So there are no devices that we use. There's no
Mhm.
integrators. There's no heat packs. There's no decompression tables. Everything is done by our hands because we consider our hands our listening devices when we do OMT. Um,
Mm,
there are some similarities, and actually, the first chiropractors were originally DOs, and there's a field shift, but
mm.
there's a couple differences there. OMT is also billed by, under your medical insurance, so it's considered an in-office procedure. In chiropractic, some people's insurance don't have any coverage at all, but they may have OMT coverage, and it's something to look into.
Okay, that's okay. Thank you. Um, do you also like, I know a lot of people are asking about sort of integrative type, holistic type interventions. Is that something that, I don't know, are you familiar with that, or how does an osteopath or physiatrist?
Absolutely. So, we try to take a whole body approach to it. And, one of the things that when we look at a whole body is thinking about nutrition,
Hmm.
supplements, sleep, hydration. That plays a whole role in a lot of different things. And that kind of goes into our non-pharmacologic ways of managing pain and discomfort. Um, sometimes an anti-inflammatory diet is something that I can recommend to a patient, and
Hmm.
they're like, "What's an anti-inflammatory diet?" And then we go through that, and
Hmm.
that type of information can be really useful because you learn what to buy and what not to buy, and that can be really helpful.
Great. Are there, um, and people are asking about autoimmune illnesses. Is that something you treat within your practice, or we work closely
So
with a rheumatologist, or how?
yeah, so we'll work if a patient has an autoimmune disease, we definitely can evaluate and treat. We don't prescribe any of the immune modulating medicines. So, for example, Humira is a big, very common
Mhm,
rheumatologic medicine. We won't write that. That will be with the rheumatologist. However, we know that Humira causes joint pain and stiffness and stuff like that. And so you might be seeing me, so I manage your knee brace,
mhm,
or I write your physical therapy to have them focus on that. So that's why I say we are kind of a collaborative field because,
mm,
not everybody, you might need multiple specialties to help mitigate a condition. And we
mhm,
have that kind of nistic that focuses on quality of life versus they may have the kind of the cellular treatments that you need
mhm.
to treat it.
Those issues, okay. And someone's asking about how often or do you work with degenerative disc disease?
Every single day in, day out. It's probably
Yeah,
half of my patients. Yeah.
most of them, yeah, I'm
Yeah.
sure. Absolutely. I know you mentioned this, but someone's asking about age limits to the patients you treat. You said you're working with someone quite older, many, quite advanced age.
Yeah. So typically we see adults.
Mhm,
However, on case by case, we will see teenagers and children. For OMT specifically, I will see some newborns for colic and tongue tie. But my patients are typically 16 and older.
okay. Okay. Oh, this is an interesting question. To your knowledge, are there any breakthrough therapies today or on the horizon that will prevent one from needing a knee or hip replacement? Anything you're aware of?
Yeah, that's a good question. I think one of the
Hmm.
things that we're trying to bring to Valley, and hopefully will be going live next month, is something called
Hmm.
platelet-rich plasma. Um, Platelet-rich plasma is under the auspices of what they call regenerative medicine,
Right.
where you draw your own blood. Um, well, we draw your blood, we spin
Hmm.
it down and concentrate the platelets. When people have an injury like a cut, the platelets are the things that come in and kind of, basically clot and scab. And we know that those platelets have cell signaling factors that control for pain as well as to lay down collagen. And what we're
Hmm.
learning is that if we put those concentrated platelets in areas of discomfort, like hips, like knees, like rotator cuff tears, that people can get some significant pain relief. And we're hoping to bring that to Valley next month.
Oh, that's very exciting. Great, great. Um, Wonderful. Maybe you could put your slide back on where you're with your
Sure,
information. That's
absolutely.
so, I think people be very interested in possibly working with you. And I know you have two other physiatrists working with you at this time.
Yes, we have Dr. Samuel Jacob and Dr.
Mhm.
Michael Chen. Both of them practice here, and Dr. Jacob practices also in our Wayne location. And Valley anticipates opening its Montvale practice, believe in July as well. And Dr. Chen will be going up to Montvale as well. So we will have physiatry coverage throughout Bergen County and Passaic County now. that we can definitely be of service.
Oh, wonderful. Thank you so much, Dr. Nunziata. This was excellent. Really appreciate your time.